with great pleasure that I introduce our keynote speaker, Dr. William Yang. Dr. Yang is the chairman of Red Maple Trials, Inc., Allergy Research Corporation, Yang Medicine Professional Corporation, and the National Capital Allergy Laboratory Services. He is a clinical professor at the University of Ottawa Medical School and was the former head of the section of allergy and clinical immunology with the Department of Medicine at the Ottawa Hospital. He's also a member of the board of directors of CHAIN and an active member of the board of directors of the Canadian Allergy, Asthma, Immunology Foundation and past president of the Canadian Society of Allergy and Clinical Immunology. He's very active as a clinical researcher, and he is active in clinical research in hereditary angioedema and a number of other areas, including asthma, peanut allergy, allergen immunotherapy, vaccine development, and presents at therapeutic conferences internationally on various topics related to these areas. He's published over 150 scientific abstracts and papers in peer-reviewed journals. So without further ado, Dr. William Yang.
Thank you, Tim. Thank you. Thank you, Tim, for your kind introduction. Yes, I'm very privileged to be standing here giving this presentation at the outset. I'd like to acknowledge HAE Canada and its board of directors, specifically Tim House, for making this presentation possible. Special thanks and forever grateful to all HAE patients who participated in the clinical trials research over the last 10, 12 years so that we have better treatment options. Special thanks to all HAE patients and their family for their support and also my office staff. It goes without saying that without their help, there's no way that we would be here today talking about our research. And special thanks to Stephanie and John O'Quinn and all my office staff. So the objective of the talk today is to review the pathogenesis of HAE and to discuss and review with you the clinical manifestation of HAE and discuss the current and upcoming treatment for HAE in Canada. And also I will present a couple case studies to share with you our experience. Further discussing the burden of HAE on the quality of life for HAE patients, and I answer any question that if you may have. So HAE, the mediator system involved in pathophysiology of HAE is very complex. It consists of complement system, bradykinin system, fibrinolytic system, coagulation system, angiotensin, renin system, and hormone. The status of the involvement of each system, it remains largely unknown. The best slide that I can come up with is the published in the New England Journal of Medicine explaining the pathogenesis of HAE. It consists of three cascades. On your left-hand side is the coagulation cascade. In the middle is the complement cascade. And on your right-hand side is a contact cascade. When these systems were activated, it leads to activation of each pathway. The end result is inflammation causing the tissue leaking, endothelial leaking, inflammation of the tissue causing local pain, and also the edema and increased clotting system. On your right-hand side, and you can see, and also in the middle column, adding C1 inhibitor into the patient system restore the homeostasis of all these three systems. However, the ecallantide and also icatibant, they work on the bradykinin system, and they do not affect the complement and coagulation system. Now, clinically, how do patients manifest? Characteristically, they have episodic swelling in various parts of the body, and these swellings are deep-seated, and life-threatening laryngeal edema could happen. Oftentimes, there's swelling of the abdominal mucous membrane. There could be fluid accumulated in the bowel, causing ascites. The severity of the swelling varies from one to another. By and large, the edema is self-limiting. So there are two types of HAE. Type 1 HAE represents about 85% of cases. Typically, the C1 inhibitor protein is low, and C1 inhibitor function is also low. C4 level is low, whereas in type 2 HAE, the C1 inhibitor level could be normal or high, where the C1 inhibitor functional activity remains low. C4 also is reduced. This type 2 represents about 15% of cases. Clinically, the type 1 and type 2 cannot be, the manifestation is, type 1 has the C1 inhibitor level is reduced, and C4 is reduced. The functional assay is also reduced, whereas it represents about 85% of cases, whereas type 2, the C1 inhibitor level could be normal or high, whereas C1 inhibitor functional activity is reduced and C4 is reduced. And this represents about 15% of cases. Overall, both type 1 and type 2 are clinically indistinguishable, so they all present it the same way. HAE is an unpredictable and serious condition. It can affect all organ systems. It's a multi-organ disease. It can affect the face, the larynx, the abdomen, genitals, and extremities. HAE can be life-threatening and debilitating too. And on your left-hand side is a lady with HAE attack with swollen face and lips. After treating patient with Barinet intravenously, on the right-hand side is her face and lips after Barinet treatment. Clinically, it can affect the face, the lips, soft tissue, the extremity, upper, lower, and larynx, and abdomen, as well as genitalia. HAE is a life-threatening disorder. It has been reported up to 40% of HAE patients can be potentially fatal. In a retrospective study showing that over 50% of patients, they have experienced at least one episode of laryngeal edema, which really fits very well with the survey team did a little while ago. In a cohort study, 30% of patients died of asphyxia because of laryngeal edema, and 30% of these patients who died before HAE was even diagnosed. This is a CT scan of the abdomen showing that on your right upper hand corner, you see that there's a small bowel of swelling and shown up in the CT scan of the abdomen. Next slide, please. And on the left, there's another CT scan of the abdomen showing that fluid accumulation near the liver area, perihepatic edema. Next page, please. So this is classically the blood test. When you do blood tests, you see the HAE patient, the C1 inhibitor is low comparing to the normal individual on your right-hand side. Next slide, please. HAE is a rare autosomal dominant disease, meaning that the child of affected parent has a 50% chance of inheriting the abnormal gene. Thanks. So screening patient is very important. A global online survey showed that only 48% of immediate family members and 25% of extended family members had been tested for HAE. So we need a lot of work that we need to do. And a cohort study of 728 patients from 182 families with HAE showed that out of 214 patients who died, 33% of them died because of asphyxia due to laryngeal edema. Out of these, 30% of them died before HAE was diagnosed. For those who were diagnosed, 3% of them. That only represent 3% of them. So screening family member is not only immediate family, but extended family is recommended. Next, please. So Canadian HAE guideline was published under the leadership of Stephen Batchel last year. Basically, the recommendation said that for acute attack, effective treatment should be used to treat acute HAE attack in order to reduce the duration and also severity. Early treatment is recommended. All attack involving the upper airway should be considered as medical emergency. One should treat the attack ASAP, and these patients should be referred to emergency as soon as possible. Prophylaxis, long-term prophylaxis may be appropriate for some patients to reduce the frequency, duration, and severity of the attack. All patients should be trained on self-administration, which I think the survey agree with that. Majority of patients in the Ottawa area, by and large, are on home infusion. Other consideration, decision to start or stop long-term prophylaxis depend on many factors and should be made between patient and the HAE specialist. Comprehensive care should be available for all patients with HAE. A key point, just to summarize what I just said. It is a rare autosomal dominant disease characterized by painful, unpredictable, recurrent attack of inflammation and edema affecting the extremities, face, abdomen, and larynx. Laryngeal attacks are potentially life-threatening. It is a genetic disease, and family members often go untested. Guidelines recommended early effective treatment for acute attack, as well as consideration for prophylaxis for some patients. It should be referred to see an HAE specialist and should be managed by a comprehensive care team. Thank you. Now, what are the factors that triggers HAE? It is interesting. Stress is commonly triggered HAE attack, trauma, surgical, or what other, and insect bites, contraceptive, especially estrogen, menstruation, surgery, drugs like high blood pressure medication, ACE inhibitor, certain viral infection may trigger the HAE attacks. Now, the first occurrence HAE symptom has been debated in the literature. General consensus is that by and large, the HAE manifested before the second decade, before the 20 years of age, based on the previous publication. Next slide, please. So Mark Ryder, published in Current Allergy Asthma, reported that the mean age of diagnosis was 16.8 years of age. However, there's a mean delay of 9 years, again in agreement with the survey team just did. Next page. We, in Ottawa, our team had looked at the early manifestation of clinical HAE in an infant. Next slide. Yeah. We have taken blood from newborn babies through umbilical cord and as early as possible. We came to several interesting cases, some with low C1 inhibitor and low C4 with no symptoms. But there's one particular infant that manifested symptom at a very early age of 9 months. Next page. So this is interesting. Of umbilical cord blood showed that C1 was low, C4 was low. This was repeated at 18 months, and the C1 inhibitor was low, and C4 was low. And if you look at the right upper eyelids, you see the swelling, edema of the upper eyelid, and the right cheek appears to be puffy as well. Next slide, please. This beautiful baby also demonstrated a rash known as erythema marginatum at 14 months and 18 months. Next slide. So in conclusion then, the HAE, clinical symptom HAE can begin as early as 9 months without any triggers. So parents and clinicians need to be very vigilant and properly diagnose HAE to optimize the quality of life of these young patients and their families. we emphasize a high index of clinical suspicion in HAE. It should begin even in the early infant period. So we believe that this case is probably the youngest HAE, symptomatic HAE patient ever reported. We're in the process of writing this up, hoping that this could be published in a scientific journal. Just briefly to go back on the history of HAE treatment. In 1882, this was the condition of angioneuritic edema was first described by Quink. And the description was angioneuritic edema. In 1888, Sir William Oslo identified the disease as being genetic. However, in 1961, C1 inhibitor was isolated. Donaldson reported a functional deficiency a year later. Danazol prophylactic treatment using danazol started in 1976. 1977, I believe I was a senior fellow at McGill University. At that time, C1, Avandis-Baring, C1 inhibitor concentrate became commercially available. In 86, the for C1 inhibitor was localized, was identified on chromosome 11. And complete analysis of gene structure was completed. In 86, it was pasteurized. So it took a long time, almost 45 years, because in 77, I remembered at the Royal Victoria Hospital, one of the major teaching hospitals at McGill, we were still using fresh frozen plasma to treat acute attacks. It took 45 years for us to come to today that we start having new products. Next slide, please. Prophylaxis. We rely on C1 inhibitor to treat acute attack as short-term prophylaxis, and also in case of rare attack, C1 inhibitor was solely used for many years. And then later on, the patient-oriented long-term prophylaxis with danazol, androgen, began for those with at least one acute attack per month. Permanent treatment C1 inhibitor, in case patient cannot take danazol, anabolic steroid, because of age, because of being female of childbearing age. In those situations, one considers C1 inhibitor prophylaxis. Next slide, please. The dosage of danazol should be as low as possible. Initial dose should be higher to achieve an effect, and quickly the dose should be reduced. 200 milligrams per day is the upper limit for long-term prophylaxis. For those who's on danazol, one should have annual ultrasound of the liver to make sure that they do not develop a hepatic tumor, either benign or malignant. Also, liver function tests should be done on a regular basis to make sure that they do not do not suffer from hepatic necrosis. Now, next page, next slide, please. Long-term prophylaxis with danazol can be used for frequent attackers. However, side effects are very, very significant. One should be aware of this. For example, women don't like using it because they grow hair on the face and the voice change. They disturb the menstruation as well, weight gain, and the risk of hepatic tumor and mental disturbance. The side effects are partially reversible depending on what type of side effect one gets from danazol. Next page, please. This is a slide showing the C1 inhibitor level of acute attack using C1 inhibitor. You see the green line at the bottom shows the placebo group. Early on, someone asked me about a C1 inhibitor. Does it fluctuate? When you look at this placebo group, it's pretty much stable. Once they are low, it remains low. However, to answer your question, whoever asked me early on, yes, the functional activity of C1 inhibitor does fluctuate during an attack. However, C4 remained pretty much consistent during or after attack. Next page. On your left-hand side is a lady with acute attack, facial and swelling of the lips, and after treatment with C1 inhibitor, Barinet, she looked normal. Now, this is an impact study that Canadian participated. Thanks to many of you here who participated, I can recognize at least 6 or 7 individuals who participated in Impact 1 study. Basically, what it showed is that this study showed that the effective dose for C1 inhibitor using Barinet is 20 units per kilogram. And next slide, please. And the onset of action happened within about half an hour. In other words, once it is infused, within half an hour, they're much better. 10 units per kilo is not effective. They behave almost like placebo. Next slide, please. Again, this treatment using 20 units per kilo is effective and safe, and it is well tolerated by patients. Next slide, please. So just to briefly review Barinet before I leave the topic on Barinet, I'm sure the question will come back, that it is a purified C1 inhibitor given intravenously for acute attack, approved in Europe, in Canada, and US. There's no evidence of viral transmission of either hepatitis A, B, C, or HIV for more than 3 decades. Thank you. Now, talking the second product, which is icatibant, Firazyr. This is a monumental study involving Europe, Canada, and US, in which 4 Canadian sites participated from Edmonton, Ottawa, Hamilton, and Quebec City. Next slide, please. What basically showed, make a long story short, is that icatibant, Firazyr, is effective comparing to placebo, and also when this is comparing to tranexamic acid in both phase 1 and phase 2 after the censoring patient taking rescue medication. This was published in the New England Journal of Medicine. Essentially, this is what the slides show. This was, next slide, please. Yeah, and highly effective. Next slide. And showing that time to onset of symptom relief, it takes about 2 hours to start seeing an effect. 3 hours to become effective. Next slide, please. The second 3 endpoint also was met, and Firazyr took about 1.5 hours to have the time of onset primary symptom relief comparing to placebo 18.5 hours. Next slide, please. The second 3 endpoint, time to almost complete symptom relief, was also met. It took about 8 hours for Firazyr, icatibant, for symptom to be completely gone, comparing to 36 hours in the placebo group. Next page. This is a laryngeal attack. In phase 1, phase 1, phase 2, and phase 3, consistently show that it is effective in treating laryngeal attacks. Next, please. Over repeated treatment, icatibant provided a consistent onset of symptom relief, varying from 2 hours to 2.4 hours. Next slide, please. So this is interesting. This is a fast open label study showing that using icatibant, Firazyr, to treat acute laryngeal attack. What it said is that more than 90% of HAE attacks were treated with a single icatibant injection, regardless of location. Very few patients require second or third injection. This is a paper that was published and presented at the American Academy of Meetings showing that early treatment with icatibant, Firazyr, reduced attack duration. The sooner you initiate the treatment, the sooner you get better. So there were questions from patients in Halifax saying that how soon is considered soon. Well, patients understand the prodromal, that the attack is coming. So my answer to that is within 10-15 minutes, start the treatment. The sooner the better. You know that your abdominal attack is coming, so you don't wait until you can't move. So you got to start treating right away within 10 minutes or so. Now, this is another interesting piece of scientific data presented at the American Academy in San Diego, showing that irrespective of the use of long-term prophylaxis, some people are using danazol, tranexamic acid as prophylaxis, regardless, when they have an attack, icatibant, Firazyr was used, and it is effective in over 90% of patients with a single injection of Firazyr. Thank you. So just to summarize on the icatibant Firazyr, it is a competitive antagonist selected for the bradykinin beta-2 receptor. It is indicated for acute attack of HAE in adults over 18 years of age with C1 inhibitor deficiency. It is given subcutaneously. It's provided in a single-use pre-filled syringe containing 30 milligrams that can be stored at room temperature. Does not have to be refrigerated. Okay. The common side effect of Firazyr, icatibant, is at injection site, 97% of patients would develop a rash. This rash is red, somewhat slightly burning, not itching, and no treatment is necessary. It goes away by itself. So again, on Firazyr dosing, the recommended dose is 30 milligrams by slow subcutaneous injection over 30 seconds in the abdominal area. Additional dose may be administered at 6-hour interval. If clinical response is not satisfactory, one can repeat another 30 milligrams 6 hours later. No more than 3 doses in any 24-hour period is recommended. The advantage of icatibant Firazyr is that no dosage adjustment is in patients with liver disease or kidney disease is necessary. However, patients with laryngeal attack may receive icatibant. It is recommended they go to nearby emergency for further observation. Next slide, please. Now, this is the housekeeping issue. Patient may self-administer Firazyr upon recognition of the HAE attack. These patients should be trained in subcutaneous injection technique by a healthcare provider, ideally, and the first injection ideally should be performed under the supervision, guidance of healthcare provider. Next page. So HAE is a rare and potentially life-threatening disease, and icatibant is effective in the treatment of acute HAE attack for those with C1 inhibitor deficiency. It is indicated for those 18 years and above. It provides a rapid onset of symptom relief, and the most common side effect that one sees in over 97% of them are skin rash at the injection site, which is transient and no treatment is necessary. Next slide, please. So it is approved in Europe, US, and more recently in Canada. Next slide. Now, another product from Shire is a non-filter C1 inhibitor concentrate Cinryze. It is highly purified, given intravenously, and is lyophilized and manufactured in the Netherlands. It is approved in Europe, US, and Canada for prophylaxis only, not for acute attack. And the study have shown that it is quite effective in the HAE attack and comparing the placebo group. Next slide, please. And it met the primary endpoint of reducing HAE attack, and next slide, please. And also met the secondary endpoint of reducing the severity of HAE attack, reducing the mean duration of HAE attack, and days of swelling. Next slide, please. The third product is Acalandite from Diex from Boston that we did research on. All Canadians participated in the study, again, thanks to all of you guys. It is a kallikrein inhibitor. It is approved in US for acute attack. It has to be used in a hospital setting only because of the risk of anaphylaxis. And the fifth product is a recombinant C1 inhibitor from Pharmain from the Netherlands. Again, many of you participated in this study. It is a recombinant C1 inhibitor harvested from milk, rabbit's milk. It is effective in treating acute attack given intravenously, approved in the US, Europe, for the treatment of acute attack, but it's not available, it's not approved in Canada yet. So a patient with rabbit allergy, it is contraindicated because it can provoke anaphylaxis when given it intravenously. The recommended, go back one slide, please. The recommended dose of the recombinant C1 inhibitor is about 50 international units per kilo. There's no need to give 100 international. It's very effective. Thanks, John. So the next slide was shifting gear to HAE with normal C1 inhibitor. Some question came up on how do we diagnose HAE with normal C1 inhibitor. Some people call it the type 3 HAE, but the proper terminology is still HAE with normal C1 inhibitor. The age of these individuals, by and large, is around 26 years of age versus 11.7 years of age with classic HAE. Normally, it's predominantly affecting female subjects. 50% of them experience abdominal attacks. Tongue swelling is very common. We don't see erythema marginatum, the rash. These patients, they have long disease-free period. There's low penetrance, meaning that even though they have a mutant gene, clinically it is unpredictable when they're going to have clinical manifestation of HAE, possibly due to environmental or lifestyle factors. This is what low penetrance means. Less common than HAE type 1 and type 2. Next slide, please. The diagnosis of HAE with normal C1 inhibitor in those with recurrent angioedema without urticaria or medication known to cause such as ACE inhibitor, normally the blood levels C4 and C1 inhibitor are normal and the functions are normal. This could be due to factor 12 mutation, or they may have positive family history as well, and they normally do not respond to high dose antihistamine. So I hope I answer that question. I can't remember the question that was asked, but we can address that later on maybe, okay? Now I'd like to share with you the two cases that I selected. The case number one is a 25-year-old young lady. Onset of HAE started at age 5. The typical attack involved the abdominal cramps, nausea, vomiting, hands and feet swelling. C4 was low and C1 inhibitor was low. Next slide, please. The trigger commonly consists of menstruation, school exam, stress at home, stress at work, even though that could be part-time work. Frequent attack every 10 days. She's a frequent flyer, going to Ottawa General Hospital emergency room, receiving C1 inhibitor infusion, 1,500 units. She has poor vein. Even the IV nurse has difficulty starting an IV. So we switched her to Firazyr, icatibant, 30 milligram sub-Q. The result was not satisfactory to her, so she switched back to C1 inhibitor using a Hickman catheter for self or home infusion. Next slide, please. The second case is also another wonderful young lady. Onset of HAE started at the age of 5. Both mom and brother have HAE. Typical attack with trigger consists of abdominal pain, nausea, vomiting, hand and feet swelling. Frequent attack every 2 weeks, going to emergency. C4 was low, C1 inhibitor was low, receiving C1 Baronet 2,000 unit IV at the Ottawa General Hospital. At age 18, she participated in HAE clinical trial. the first case, the first young lady also participated in many studies as well. And July 2009, I recall this, prior to her wedding, she was concerned that she might have an attack during the wedding ceremony. So she came to my office and we infused her with 2,000 units of C1 inhibitor prior to the wedding ceremony. It was uneventful. Later on, she went on honeymoon, Royal Caribbean cruise. We provided her with action plan and 4 vials of C1 inhibitor. She had an attack on the cruise and received baronet intravenous infusion under the supervision of the cruise doctor. Subsequently, she was trained to do home infusion, and then she developed a number of episodes of laryngeal attack, and she was provided with 8 vials of C1 inhibitor prior to her trip to go to Hawaii. So, next. So, our team, under the leadership of Stephanie, managed to switch everybody from going to emergency, receive intravenous C1 baronet to, she trained all of them to do home infusion for different reasons. Some were due to lifestyle, others due to frequency, and one individual due to the fact that he would like to stop danazol. These treatments were provided by their spouse, the sibling, sometimes the neighbor. Next slide, please. So we also undertook another project for helping these individuals with HAE locally for those who went through major or minor surgery. Quite often, patients are concerned what will happen to them during the operation. Many times, it's a surgeon and anesthetist refuse to operate unless we, as allergists, immunologists, are on board to help them. Next slide, please. So over the last 15, 20 years, we have helped to give preoperative C1 inhibitor for many individuals undergoing major or minor surgery, such as aortic valve replacement, dissecting aneurysm, aneurysm repair, pregnancy, and also some dental surgery as well. Thank you. So several therapeutic paradigm for HAE, we talk about C1 inhibitor, bradykinin inhibitor, and kallikrein inhibitor, which is not available in Canada. We discuss about genetic counseling, screening. Patient should be screened, the family should be screened. And for those with Porter cat, Hickman cat, it is important to make sure that the site don't get infected so that they don't become septic. This is a risk of having a Hickman cat or Porter cat. So VON nurse will have to go to the house and make sure that this is aseptic technique is used all the time when given C1 infusion. Avoiding oral contraceptive, hormone replacement, especially estrogen, is very key. ACE inhibitor for blood pressure, one should always avoid ACE inhibitor. Next slide, please. So the general principle is, to summarize, is to treat attack as early as possible. Consider the treatment, acute treatment for all attack that could cause debilitation, attack involving face, neck, abdomen, and even deep hands and feet. All patients should have sufficient treatment available to treat at least 2 attacks. They should be provided with enough treatment, especially if they are from a distance. They should report to hospital immediately should they develop laryngeal symptoms. They should initiate a treatment and go to emergency. It is very important. For those who have frequent attack and the treatment is unsatisfactory, prophylactic treatment should be considered. Next slide, please. So we discussed all these, and then just want to emphasize the use of adjuvant therapy when indicated in a hospital setting. Those with abdominal attack, vomiting, cramps, they should be provided with IV fluid hydration, pain management, and supportive care to maintain the airway. Next slide, please. So early treatment with acute attack, this is scientific evidence that if you treat early, you get reduces the duration of swelling. This was presented in Geneva, European Academy of Allergy. Next slide, please. Now, how do we make a decision as to when to switch to long-term prophylaxis? Next slide, please. Now, frequency of attack, we need to consider how frequent, more than one a month, rapid progression of the attack. Those who have laryngeal attack, one should consider prophylactic treatment. And those who had the emergency room visit, intubation, hospitalization, intensive care unit visit, because of HAE attack, these are the candidates one should consider long-term prophylaxis. And also the burden of activity on daily living, that is, they're missing a lot of work because of attacks and affecting the lifestyle. They're becoming more and more dependent on pain medication like narcotics. So these are the individuals that we need to consider long-term prophylaxis. Next slide, please. Now, this is interesting about the quality of life of a patient with HAE is poor when compared to the general population. Studies have shown that depression increases with attack severity. Next slide. The anxiety is mounting in patients with HAE attack. They worry about the future attack. They worry about that they're going to pass the HAE to their children. The HAE attack have impact on patients' activity and education, more so in the most severely affected patient. This is what the studies show. For those with HAE, the absenteeism is much higher for those with frequent attack, severe attack, in both patient as well as caregivers. Next page. The study published that it has a potential to hinder the patient's education and employment, their employment, in both US and Europe, so it is a very serious disease. Now, this is a slide that our team, Stephanie and others, have prepared and was presented in the form of a poster abstract in both the IACI meeting in Denmark, Copenhagen, last year, as well as in Quadia in San Diego, and recently in Canadian Society of Allergy and Immunology. What I want to draw your attention is the currently approved treatment in terms of treatment of acute attack. On your left-hand column, you see Canada. What is available is Berinet. It's available for acute attack. Icatibant is available for acute attack. Whereas in US, we have more checkbox right there. They have Berinet, and they have a recombinant C1 inhibitor. They have kallikrein inhibitor. They have bradykinin antagonists. In Europe, also, they have much more treatment options than us. So we are lagging behind. We need to catch up. We need to participate in research. We need to catch up so that we have more treatment options for you guys. Next slide, please. Short-term prophylaxis, again, in the US, the C1 inhibitor, plasma-driven, there are two products available. Cinryze is approved in the US for long-term prophylaxis, and abalosteroid is approved in the US, but not in Canada. And in Europe, they have two approved products, both Berinet and Cinryze, whereas in Canada, we have Zip, nothing there, blank, even though we are using the treatment, whether it's approved or not. Long-term prophylaxis, again, US has two options. Europe has one option, and basically Cinryze. Whereas in Canada, we have Cinryze approved, but we do not have the supply due to manufacturing problems. Next slide, please. So key point take-home message is HAE is the management is rather complex and no one size fits all. HAE is a variable and complex disease with very significant impact on patients' life. When deciding on HAE treatment, it is very important to consider the severity, frequency, the impact of the disease on the quality of life, on the job, on the family, the life of the caregiver. And one need to make sure that they have access to effective, well-tolerated HAE-specific treatment. And treatment should be individualized in order to achieve proper management. These patients should have regular follow-up feedback assessment of treatment outcome between patient and healthcare provider. Next slide, please. At the end, I'd like to thank my team for making the care of HAE possible in our office, in our clinic, and also research. Next slide, please. The work is not completed. It is a teamwork. We need patients, we need HAE Canada, we need a physician who is dedicated to do research. So we need to work together, along with other physicians, emergency department, pediatricians, genetic expert, and only as we work as a team, then we will be able to be successful in terms of getting more treatment options down the road. Thank you.